Good afternoon, everyone, and welcome to Grand Rounds. My name is Tom Ford, and I'm the chair and organizer of Grand Rounds. Every the first Thursday of each month, the Centre for Medical Education takes a slot uh, broadly under the title of scholarship, and we've had a wide range of different presentations under that umbrella. And Today we're joined by Dr. Dulmini Karunaratne, who is a lecturer in the CX Centre for Medical Education, and she has an interest particularly in clinical reasoning. Of course, all of us should be striving to be experts in clinical reasoning, whether we are or we're not. There's always more to learn, but it is a cornerstone of what we do in clinical practice, and something that we perhaps don't talk about enough. Um, so, Delmini, thank you very much for coming along to talk about this area of expertise. I'm very much looking forward to hearing your talk. For those in the audience, usual Zoom rules, mute your microphone. Feel free to leave your camera on if you wish. Questions in the chat or questions at the end in real life. So thanks very much for coming along. Looking forward to hearing your talk.
Okay. Thank you, Dr. Fadden. So good afternoon, everyone. It's a great pleasure to be here today and to talk to you about this topic, contemporary evidence on clinical reasoning and its applications in practice. So I'm Dr. Dilmini Karunaratne. I'm a lecturer at the Center for Medical Education, and I come from a medical background, but I've been in medical education, full-time medical education for several years now. So when I first started researching clinical reasoning, I thought that I knew the concept and the area very well because of my background. But then I later realized it was not so. So I found it really interested in understanding the underlying mechanisms and the theories behind how we practice or how we educate our trainees in the clinical context. So I thought of for today's session to talk about these basic, like the key concepts related to clinical reasoning and share some of my research efforts related to this area. And I would also be very interested in hearing your thoughts and experiences on the area as well, even beyond the talk. So this is a quotation or a reflection I came across when I was marking a student assignment recently. And this actually resonated with my own experience as an undergraduate and a junior doctor a long time back. And it also took me back to one of the studies I did a few years back, talking to junior doctors back in Sri Lanka, where I'm originally from. So they are like similar to Foundation Year 1 doctors in the UK. So I was observing their practice, recording their consultations, and then later asking them some questions to understand the reasoning behind their questioning and the consultations. And also I was asking what's the difference they see between now practicing as junior doctors and as undergraduates, and they shared similar experiences. For example, they were saying there's a big difference between now how they practice as junior doctors and before as undergraduates. And at that time, they were trying to fit the history that they take from the patient into one of the long cases, preset long cases they had in memory. So it's not like reasoning at the moment with the patient problems. And they were saying that they were almost like parrots and robots just doing what they were asked to do. And however, it was not all negative. There were positive things as well. They were talking very highly about the exposure to like shadowing experience, the assistantship program, and that gave them more confidence in practicing as future doctors to understand what is expected out of them as junior doctors. So in this talk, I would like to invite you to review the evidence with me on how clinical reasoning develops and where it can break down in practice. and to reflect and deepen your insight into your own clinical reasoning processes. So if you are a clinician, you can make that implicit reasoning explicit to your trainees, and to recognize opportunities to develop clinical reasoning skills among trainees. So the problem here, or why should we be talking more about clinical reasoning and encouraging development of these skills? It's because that reasoning deficiencies can manifest as diagnostic errors in practice. And evidence say that the error rate is roughly around 10 to 15%, leading to patient harm. And cognitive processes, or the processes related to thinking and reasoning, are the root cause of a majority of diagnostic errors. And the evidence accumulate confirming this concern even today. So when we look at the medical training, we can see a lot of evidence coming from across the world confirming that how difficult it is for undergraduates to develop these skills and how stressful it is, and the steep learning curve graduates experience developing these skills when they transition from a graduate to a junior doctor. That said, I appreciate that in the UK and some other countries, there are a lot of efforts are in place to improve development of these skills. So the outlook may be more positive than reported, and we will maybe see better outcomes in the future. So this is what I mean by clinical reasoning for this talk. Some of you may have your own definition of clinical reasoning. So clinical reasoning is not a simple task. It is a complex task, a complex construct, and it requires you to meet the expectations of many stakeholders. So based on evidence, what is written on this area, the earlier definition of clinical reasoning is actually it is something related to the thinking processes of an individual in diagnosing and managing patient problems. So this involves skills like problem solving, critical thinking, and use of different types of knowledge. And the current conceptualization is that it is not only a cognitive process, but it is heavily influenced by many contextual factors related to the doctor, patient, and the clinical encounter. So as you can see, there are a number of factors related to these three areas, and this is not an exhaustive list. For example, the physician-related factors includes knowledge, but in addition, things like the ability to self-regulate, the motivation, emotions, whether they are well rested or not, and then patient-related factors such as whether it's a common presentation or a rare presentation, and any language barriers, whether it's a challenging patient questioning the doctor's diagnosis or the credentials, and then some practice-related factors like whether it's the outpatient clinic, inpatient clinic, the workload, the appointment length, staffing, all these matters when it comes to clinical reasoning. So in practice, this means that when a student reason with a patient problem, their reasoning in that particular situation may not be the same when they reason with the same problem, maybe with the same patient or a different patient in a different context because of the influence of these contextual factors. And that highlights that as educators, it is important for us to sample the a broad spectrum of the trainees' behavior across different contexts and cases in order to fully understand their clinical reasoning ability. And this brings us to talk about what does clinically relevant knowledge looks like, because we always talk about that students find it difficult to translate their theory knowledge into practice. So what does this clinically relevant knowledge look like? So here one important concept is the illness scripts concept. A script is organized, it's an organized knowledge structure. So even in everyday life, we use scripts to understand many things. For example, we may have a script for a table. So that helps us understand that it has a flat top and legs so that we can have a reasonable expectation of what it can do, its functionalities. So similarly, an illness script is like it's a highly organized, experience-based knowledge structures on diseases, and these are applied during patient problems. So if you represent this in a diagrammatic way, an illness script has 4 types of knowledge. So these are enabling conditions, fault, consequences, and management. So it includes information about who gets the disease. So basically about the predisposing conditions, comorbidities, and what goes wrong in the body. That is the pathophysiology, anatomy, biochemistry, physiology, everything comes there. And then how does it present, the signs and symptoms, and then how it is managed. So you can think of illness scripts, it's like a folder in the clinician's mind labeled under different diseases. So each folder will have these 4 documents. And with more and more experience, there'll be more information accumulated in these documents, and an experienced clinician will develop rich illness scripts with lot of clinically relevant information. So if we compare this to a novice, their illness scripts, when they start developing these illness scripts, they will develop these folders, and they will have these 4 areas of knowledge, but it will be rather incomplete, not very well developed as an expert. And how are these illness scripts applied in practice? So it is called activation of illness scripts. So it happens this way. So when an experienced clinician sees a patient, they recognize these clinical features the patient is presenting with. And this leads to activation of several relevant illness scripts in their mind. So this activation actually happens by recognizing the configuration of clinical features present in the patient. So it's through visual cues and sometimes through auditory cues, like listening to the presenting complaint of a patient. That also can trigger activation of several illness scripts. And there is mental matching of the clinical features presented by the patient and the clinical features that that are present in the illness scripts. The activation of illness scripts then makes the knowledge included under these 4 areas easily accessible to a person. So that's why an experienced clinician could very quickly ask more relevant focused questions on these 4 areas in order to either confirm or refute a differential diagnosis they considered earlier. And because a novice will not have these highly developed illness scripts, the process will be not that efficient for them. So when the knowledge is organized as illness scripts, evidence has found, this is all based on evidence research done over decades, over several decades actually. And when the knowledge is organized as illness scripts, it helps the clinicians to see or understand how a disease actually looks like in practice and what to do, which is really important in clinical practice. And then it brings us to talk about how does this clinically relevant knowledge develop? So if you look at our undergraduate training, medical students, they are taught on these basic biomedical principles, the basic knowledge, and this helps them develop what is called causal networks of knowledge. And these causal networks helps them explain causes and consequences of diseases. So, and because they are organized as causal networks, they will actually reason with patient problems by explaining the presentations rather than recognizing it, which can be done if they have these illness scripts. So they will need to work through the patient's problem to arrive at differential diagnosis. This is a cognitively demanding task, but it is essential for learning. And when the medical students are exposed to clinical practice and they are provided with opportunities to apply their theory knowledge into practice, it is seen that this knowledge transforms into more clinically relevant knowledge. And finally, they start developing these illness scripts. So the early organization of knowledge helps them explain how does disease develop or manifest. And then when they start developing these illness scripts, they get the ability to see how a disease looks like in practice and what to do. So therefore, our expectation for undergraduate training would be during the early part of medical training, they will develop these causal networks of knowledge as a result of basic science teaching. And when they're exposed to clinical practice, they will start transforming their theory knowledge into more clinically relevant knowledge, which we call knowledge encapsulation. And then towards latter part of training, they will start developing these initial illness scripts, which are really helpful in clinical practice. So that said, in our study, talking to junior doctors and following them up for almost 12 months, we saw that there's a gap between our expectations and what actually happens in practice. We saw that as junior doctors, when they first start practicing with real patient problems, they have a disease-oriented approach to reasoning, where they are able to explain the signs and symptoms of the patient presentation and reason through that, reflecting their knowledge organization as these causal networks of knowledge. And then later towards the latter part of their training, we saw that they developed a practice-oriented approach to reasoning, where they are able to quickly recognize the clinical presentations, and that actually reflected developing these illness scripts. And this transition was not easy. It was associated with a very steep learning curve, and there was numerous factors facilitating this transition. And we were able to categorize them under facilitators, drivers, and sources of developing clinical reasoning skills. So work experience was one big facilitator, but in addition, there were so many other factors influencing this transition, like feedback, reasoning out aloud, reflective practice, and then having this professional responsibility and accountability towards patient care, role models, internal motivation, and so many other sources of learning, including patience, teamwork, and learning from errors. And there were silencers or inhibitors of this process as well, related to contextual factors and individual factors. So the contextual factors were related to high workload, time demands, limited feedback, poor team dynamics, and so on and so forth. And also the training being more service-oriented than learning. And there were individual challenges like lack of motivation, inability to reflect in practice. And we also saw in our research that they were able to use different approaches to reasoning. So when we talk about approaches to thinking and decision making, the literature talks about two broad approaches to reasoning. One is the non-analytic reasoning, which is like reasoning, like it's automatic and effortless, like you are cycling in a free road in the countryside. And then the analytic reasoning is like, it's like you're cycling in a rocky, a stony road where you have to slow down and carefully think about the next step. So it's very analytical and deliberate. So we apply these approaches to thinking and decision making even in our daily practice. So things like, if someone asks a question for the first one, the answer to the question, and then when you see these, images, logos, you quickly, understand it. You know the answer because you've seen this repeatedly, and it just comes automatically to you. You don't really have to analyze the features and compute the answer. So this is similar to non-analytic reasoning. And if someone asks a question like this, you will need to carefully calculate it, give attention to it, and invest more cognitive effort doing this. It is like the analytic approach to reasoning. So these two approaches are applied when you are reasoning as well. So if we try to compare these two approaches, so the analytic reasoning is deliberate, conscious, rule-based, and non-analytic reasoning, or the pattern recognition, is rapid, automatic, and reflexive. And both these approaches have advantages and disadvantages. So if you think about analytic reasoning, main advantages are, because it is deliberate and conscious, you can easily justify each step of your reasoning process and easily teach it to someone else. And this is really helpful when reasoning with complex and unfamiliar cases. But the disadvantage is this is time consuming, cognitively demanding, and it is not effective, or it is efficiency wise, it's very low when it comes to reasoning with routine cases and busy work environments. So we think about the pattern recognition or the non-analytic reasoning. The benefits are it's very quick and highly accurate in familiar context, especially when it is used by experts. And this is essential in emergencies. The disadvantage is there is increased risk of bias associated with pattern recognition. However, the key message is researchers have seen that both novice and experts apply both approaches during reasoning. And actually, when it is encouraged to apply both approaches, what is called a dual process approach to reasoning, it leads to higher diagnostic accuracy. So it is encouraged in the evidence base that we should facilitate or try to develop this dual process approach to reasoning among our trainees as well. So in practice, this would mean that we need to think about whether we would like to encourage, or how do we plan to encourage dual process approach to clinical reasoning among our undergraduates, and at what level, and to what seniority, and where we could introduce in our curriculum. So, as briefly mentioned, both these approaches, the analytic and non-analytic approaches to reasoning, they have disadvantages and could lead to cognitive errors. And one main way where these errors could happen is through excessive reliance on non-analytic reasoning. So the literature talks about large number of biases, and some of these are like overconfidence bias, which is also seen among experts, and then premature closure. You stop too soon analyzing the patient's problem, and the availability bias. You are being biased by recent cases you've seen, and confirmation bias, trying to look for proof to confirm a diagnosis, ignoring other evidence. And then the other way is the defective functioning of the analytic reasoning. So this could happen through cognitive overload, time pressures, workload, and the poor emotional well-being, and including knowledge gaps. So the way forward to address these errors is to educate on clinical reasoning and to facilitate developing these skills throughout the continuum of clinician training. And we will talk about specific strategies soon in the presentation. So in one of the studies we did, we also saw that these junior doctors, they are able to apply these both approaches to clinical reasoning. But at the beginning of their training as junior doctors, their approach to clinical reasoning is more exhaustive, analytical, very cognitively demanding, and not very helpful in a busy working context. And this is highly influenced by their undergraduate training. And towards the latter part of their training as junior doctors, we saw that they are able to flexibly use these two approaches to reasoning. And it becomes more focused and problem-based. However, when they move from one specialty to another, we saw that the reasoning skills developed in one specialty actually does not automatically transfer to another specialty, and there is a time of recalibration of reasoning skills at the beginning of another rotation. This is something interesting that we saw in our study as well. So there is this specialty influence on clinical reasoning. So we were talking to junior doctors from 4 main clinical specialties: medicine, pediatrics, gynecology and obstetrics, and surgery. And we saw that some disciplines encourage more management orientation to reasoning. The specialties like surgery and obstetrics, and other specialties orient them like in other specialties there's a diagnosis orientation. So this is mostly for reasoning with non-acute presentations. For acute presentations across all specialties, they follow a management orientation, which is required by that particular emergency or acute situation. So when it comes to non-acute situations and in specialties where there is diagnosis orientation, we saw that junior doctors are able to follow a broader based clinical reasoning where they are able to reason through different components of the patient's history, understand the relationship of comorbidities, the pre-existing conditions, and how it influenced their reasoning. And they were able to identify some problems which were not directly related to the presenting complaint and address them or refer them to different clinics or other specialties. So it encouraged a more broader base to patient care. It was more holistic, and we saw that this helped develop clinical reasoning skills among junior doctors. But then when it is a management-oriented specialty, because of the nature of presentations that is presented to that specialty and the time-based pressured environment, they followed a narrower base to clinical reasoning. And this was essential in that context to provide effective care. However, because of this narrow-based clinical reasoning, we saw that they were focusing more on the presenting complaint and less on other factors influencing this patient presentation. And even if they inquired about other conditions, it was very specific related to management of that condition. So it was, and also there was more pattern recognition when reasoning with clinical problems in management-oriented specialties. And we saw that it encouraged less patient-centered and and it was not very holistic in terms of understanding the patient's problem as a whole when reasoning with reasoning in such specialties. And it was not really conducive for developing clinical reasoning skills for junior doctors. It's not really bad to have this narrower based clinical reasoning because it is what is required by the specialty. But the problem we saw was that unexamined narrowness in reasoning was not really helpful as junior doctors at the beginning of their training. So that said, it brings me to talk very quickly about some practical applications of this evidence in practice. So some of the ways that we could encourage clinical reasoning skills or facilitate its development are through these means. For example, like strengthening the clinical relevance in basic sciences teaching. So always talk about how the clinical or the basic sciences content relate to clinical practice and how they can use that knowledge in a clinical context. And explicit introduction to clinical reasoning early so that they have that vocabulary, the shared language to understand what they will see in practice and to identify that. And strategies like case-based clinical reasoning seminars, where you focus on the process of clinical reasoning through the content knowledge. So that is also found to be helpful in communicating the reasoning process to trainees and developing reasoning skills and encouraging comparing and contrasting between diseases, and also things like developing clinical reasoning maps. And another strategy would be to make trainees aware of this dual process approach to reasoning. It's not really mastery that we are looking at undergraduate level, but letting them know that this is there and they can use it, but it is associated with these kind of biases. So that, and also this helps them to, understand their reasoning and observe what is happening in practice. And also that as educators, we can think out aloud so that we can communicate to trainees how it is actually applied in practice. And other ways would be like history taking taught with purpose. And talking to students and showing them how different components of the history, matters together, comes together. It's not really about collecting all the information, and to generate differential diagnosis and reason through comorbidities and contextual factors. And also by providing deliberate opportunities for deliberate practice, repeated practice with patient problems and providing feedback. And it is found that thinking aloud and making reasoning visible helps trainees develop reasoning skills. And case discussions to be focused on the reasoning process. So rather than asking you, did you take a full history? We could ask them, why did you prioritize this diagnosis? What else did you consider? and what are the contextual factors influence your thinking to encourage developing these illness scripts. And to de-emphasize the specialty-specific narrowing of reasoning. So to encourage them to consider differential diagnosis across specialties, not being confined to one specialty. And then providing a safe and supportive learning environment, role modeling, and then opportunities like shadowing and assistantship. So that actually brings us to the end of my talk. So the key takeaways I would like to highlight is that in order to encourage clinical reasoning development, we need to provide more opportunities for our trainees to observe, then coach developing these skills and practice these skills with supervision, which will enable them to practice independently later as junior doctors. And we saw that clinical reasoning expertise is not only through experience plus reflection, and then there are so much more other factors that comes into play. And we need to we need to provide that supportive environment to develop the clinical reasoning skills. And I also understand that in Dundee and many other places, we actually do a lot of these things. And what we require maybe not to do something, quite different or make drastic changes, but to pause and reflect and see what we are doing well and what are the gaps and engage in scholarship activities to further strengthen our practices to support development of these reasoning skills. So this is the last slide I would like to share with you, inviting you to one of our studies. So we recently did a study exploring how the national cultural predispositions can shape clinical reasoning skills. And we were talking to clinical experts and people who had research experience in this area. So as a next stage of this study, we are inviting participants with who are being trained in a foreign cultural context and practicing here in the UK to share their experiences of how they navigate these cultural expectations when reasoning in new cultural contexts. So if you're interested, if you know anyone interested in the study, please share it with them. And thank you very much for listening.
Thanks very much. That's great stuff. We'll just unchase. There you go. Lovely. So I think this is very interesting. In my time in the undergraduate sphere, we tried to tackle this subject, clinical reasoning and how to teach it. It's surprisingly difficult to do. I think a lot of what we do as seasoned practitioners, old folk, is a lot of the unconscious stuff, the rapid. It just happens, and it's hard to teach because it's so experiential, and we perhaps don't spend a lot of time talking about our thought processes. I try to do that in clinics with students, trying to explain how I've got to where I've got to, but it's a difficult thing to do. And Professor Hothersall Davies, whose smiling face has appeared on my screen, will remember the work we tried to do more than 10 years ago, trying to focus on this, and it was challenging, wasn't it? But I thought your talk was excellent and a real insight into why it's so difficult. Any questions? Ellie's sound is broken on her laptop, so she's typing her questions. I shall be the voice of Hothersall. So, is part of the challenge with teaching about clinical reasoning that you need a certain level of maturity to be interested in learning about thinking?
Yes, I think so. That's an important question. But at the same time, I think as students, reflecting on my own experience as well, we sometimes think, what is the relevance of this teaching? So, and how I can apply this in practice. So I think that that relevance should be the main focus in our teaching, how this relates in practice. I think that if we highlight that focus and how this can be applied in practice, we'll be able to, facilitate the development of those illness scripts early to make that shift in their knowledge in a way that that can be easily applied in practice, because that knowledge transformation is what is seen as the main challenge, how that theory knowledge can be applied in practice. So if we can show that clinical relevance early as undergraduates, when we are taught on these basic principles, I think that is something that we can do. Of course, there will be challenges, but I think that is one way we could show how we can apply these things and how we can support their developing these clinical reasoning skills.
I mean, I really agree. I was teaching some of the first years this morning, and the respiratory block's coming next week, and we'll be doing a lot more teaching with the first years. And although there is a range of age and maturity, as comes with all cohorts, I think when you're in first year medical school, you want to know what do you need to know to pass the exam. That there is teaching to the curriculum and what's the exam and what's the barrier, what do I hit, what do I have to jump over to get to the next stage, and that's entirely valid. I mean, we're all nodding away here to that. But what we sit above all that, saying what we really want you to do is to learn how to think and how to get through challenging situations and all these things, when really what the students are often after is what's the number, what's the answer here, when in this multiple choice, do I say 5 or 7? What's it's a different this and it's when did I go to medical school? A long time ago, 30 odd years ago. Much has changed, but much is the same. And the medical curriculum is so full now, isn't it? I say to the medical students that it feels like there's twice as much medicine for me to teach them as I was taught 30 odd years ago. But this is still such an important part of it all, and something we all do every day.
Yeah.
Any other questions from the floor? Ellie has said here, just to add to that, the school system is all about learning how to pass exams, so getting out of that habit is hard. And I think we all recognise that, particularly with our early students, the first years. But they have been given teaching which is specifically directed towards, can you get your 5 A's at Highers so you can go to medical school? Can you get your 3 advanced Highers so you can go to medical school? Whereas now we're talking about how do you become a good doctor? Okay. It doesn't look like there's any hands, and there's no more questions in the chat, so I think we've come to a conclusion. So that's brilliant. Thank you very much indeed for coming along to talk. Thanks for contacting me to offer your time. And that goes for everyone. If you thanks for coming here today and giving your time. If you'd like to give a talk at Grand Rounds, I have slots in March, April, May, June, and July. So if you're sat there thinking you have a talk, or you know somebody who would be able to give a good talk, then please do let me know, get your slot, and we'll put you into the rota. Other than that, I hope the rain stops at some point. It will be spring eventually. I hope you have a nice weekend. I'm off down south. I'll be back next week with the next Grand Round, and I'll email around the details early in the week. Thanks very much again. Take care, everyone. Have a good weekend.
Thank you.